Welcome, Mary, and thank you for coming out. What we want to do today is introduce you to something new that we in CorneaGen have been doing, really developing over the past 7 years, which we're real excited about for the treatment of keratoconus. We call it CTAK, or corneal tissue addition keratoplasty, for keratoconus and corneal ectasia. It's been something that we've been working on and evolving really over the past 7 years. And it has, through different iterations in our clinical trials, it has evolved from implantation of shaped lenticles to pupil sparing donuts and an arc. So it really is what we consider to be a new intrastromal lamellar keratoplasty technique. And one of the exciting things about it is that it uses a customized corneal tissue, which has given us really very good results. And I've been very interested in keratoconus. It's about 30 years now. And this is the one thing that I've seen surgically that really has a wow factor for the patients. So many of the patients get this done, and they're really seeing so much better in addition to having their topography improved. You can see it on the screen there that the inlays, I'll show you how CorneaGen processes them in just a moment, are clear, well tolerated. They've been in our practice and what we've done in our clinical trials tolerated for several years now. And we'll go into it again in greater detail, but just looking at the corneal topographies that you see here, we've been getting profound flattening effects. And most importantly, we're able to make the corneal topography much more symmetric, which we'll see in our clinical trial has led to really, really good both vision outcomes, topography outcomes, and patient satisfaction. So let's look how the tissue is processed. What we do is using proprietary software that we've developed is take clinical data and topography and tomography data and individualize and customize the tissue per the individual patient specifications. CorneaGen processes the tissue using the Zemer Z8 laser. Zemer has done a lot of work in being able to customize the types of cuts that we make, and the quality of the cuts leads to a very smooth, clear, and reliable tissue. CorneaGen produces this tissue from standard eye bank derived tissues, but it is then rendered acellular, sterilized with gamma irradiation as packaged. So this is really clear, preserved corneal stromal tissue that can be taken off the shelf, so to speak, but we give it to you in a customized setting for your patients. The inlays are customized per the algorithm and per the CorneaGen cuts for their width, the radius of curvature, the subtendon angle, and their thickness. And importantly, also using our software, we derive a surgical plan specifically for that patient. So you'll receive, as a surgeon, a surgical plan of exactly where to place this customized tissue in order to give you the best results. Let's look a little bit at the procedure itself and early patient selection. What do you need? Well, as a corneal surgeon ophthalmologist, we need corneal topography and tomography. Typically, we've been using the Pentacam and the Zemer Galilei. We can use that input data as well as your clinical data for the algorithm that will give the appropriate inlay. You need a femtosecond laser. For channel creation, we've used both the Intralaser and the Zemer. Currently in our practice, we're using the Zemer Z8, but most femtosecond lasers will be able to do this. Now, in coordination with Katina Corza, there is an instrumentation set that has been developed. Very important is the corneal marking, because the positioning of these inlays is very important. You'll see we have CTAK forceps, channel dissectors, manipulators, all things to make this a relatively easy procedure. And of course, you'll get the CTAK segment as produced and customized by CorneaGen. The first part of the procedure is marking the cornea, and this is marked per the specifications that you will get on the surgeon nomogram that we will, and CorneaGen sends you for your particular patient. This is an off-centered procedure. Obviously, KC cones are not centered on the cornea, so we need to decenter the segments in just the right way from the pupil in order to then set our femtosecond laser, as you see here, to give us a channel in the exact coordinates that we need. Again, decentered from the pupil and properly encompassing the keratoconic cone. Here is a quick example of the treatment itself. Here we're making the channel. This is the Zemer laser. It's cut to specifications. These are the CTAK forceps and the CTAK segment. Now, you might think this is difficult to place because the corneal tissue is very floppy. And we found even if you go down to very thin inlays, quite easy to place because it does retain some kind of rigidity. So the CorneaGen tissue, being clear, importantly, is also somewhat rigid, that allows for easy placement, as you see here. Who are the first patients that you should treat? Well, we've been treating patients, as we'll see in our clinical trial, who have both marked or moderate or mild KC. But the recommended first patients are those with moderate KC, somewhere between a Kmax of 52 and 65, with moderate cones that are not too big and, importantly, not too inferior. So in selecting your first patients, be very careful with ectasia, because the corneal ectasia patients, as you know, tend to have very low cones, and these require even more customized specifications than normal. So better to stay with a more central or paracentral cone of moderate size and moderate height. Also make sure, obviously, that the patient has good visual potential, because the goal of this procedure is to give that patient a better visual function. We've also found better contact lens fitting after the implantation as well. So let's now take a look at some results. I'm going to turn the podium over to Stephen, and we can take a look at the clinical trial that we've undertaken over the past few years. Steve?
Thank you. So now that we know that CTAK is a very customized inlay, we went through the software that will customize it, the customization of the placement. So the key is now to see whether all of that actually works. And so we did a prospective clinical trial on 21 eyes of 18 patients. We're now past 60 eyes that we've placed this version of the CTAK segment in, with the results being very similar to this first 21. And this is really what excited us about all the customization. There's really no procedure on the market for keratoconus right now that is giving this level of visual results. And as Dr. Hirsch alluded to early on, this gave us a real wow factor when we placed it in the keratoconic patient, which is extremely unusual for these eyes. we were seeing on average 6 lines of improvement in uncorrected visual acuity. And in the first 21 patients, these are mostly severe, moderate, and severe keratoconic patients. So most of these patients started with vision that was just slightly better than about 2400. And on average, they ended up at around 2080 of uncorrected visual acuity. When we broke that down individually, we see that 10 eyes, 10 of the 21 eyes, almost 50%, had more than 6 lines of uncorrected visual acuity improvement. So this is really unlike anything else that's available. On the best corrected side in glasses, we see the same thing. We see an average of 3 lines of improvement in spectacle correction. And again, looking at the averages, these are patients moderate and severe that had a visual acuity of about 2080 in glasses and now got to about 2040. And so these are patients who have a real meaningful change in their glasses vision. Now, a lot of these patients who are moderate and severe still actually wear contact lenses on their day-to-day basis, but they're able to take out their lenses and actually function very well in glasses. 20/40 vision is a meaningful vision that they can use at home. They can use even on the weekend, things like that. And as we've moved to more mild cases, we're seeing the same results, getting to a real functional vision without contact lenses. Another thing that we saw, which again is unlike anything that we had seen in the past, is an actual improvement in the spherical equivalent. So these patients on average had a spherical equivalent of just over -6 and a quarter, and they had about a 5 diopter improvement in their spherical equivalent in glasses. Topographically, we're seeing the same incredible results. When you look at the mean keratometry, the average flattening for these patients was just under 8.5 diopters. The maximum K, and a few reasons why that doesn't even fully capture what's happening in these patients, is just under 7 diopters. And if you actually look at where the maximum flattening is happening in the cornea, at 6 months, we're seeing an average in these patients of 16 diopters of flattening. So this is just an amazing amount of flattening to see in some of these moderate and severe cases. But the key with CTAK is the customization. It's not that we're looking to get every cornea to flatten by 16 or 20 diopters. We're not. We're looking to get corneas to flatten to make the cornea more symmetric. So when we look at the 21 patients we treated, you can see that we flattened corneas from anywhere from just under 4 diopters to as much as 30 diopters. And it's this customization that's really the key. I think this slide really tells it all, because if you look at these 3 cases, a severe case we treated, a moderate case we treated, and then a mild case we treated, and you look at that post-op topography in the center, you can see that we're getting a reproducible, symmetric flattening in the center of the cornea, and it's customized to each case. So the severe case had 24 diopters of flattening, and the mild case 4.5 diopters of flattening, with a very, very similar post-op result. So with the remaining time, I wanted to dive into just a few clinical cases, some actual patients that we placed these segments in, and then we'll turn it over to Dr. Berdahl, and he can give some of his early experience placing these segments as well. So this was a 35-year-old female who actually had a PK in her other eye, and had become contact lens intolerant in the left eye. She was a flight attendant. She had a lot of difficulty using the lenses in the air, and it was debilitating for her life. So her next option would most likely have been a PK in this eye as well. She had actually had a rejection already of her PK in the first eye, which thankfully was reversed, and she was looking for alternatives. So we enrolled her for the CTAK trial. She had counting fingers, uncorrected vision. Her spectacle corrections 20/70, clearly not functional as a flight attendant with the refraction below. And again, drawing your attention to the topography, you're seeing these same topographic outcomes on each of these cases with this very symmetric post-op flattening after the CTAK segment is placed. And at 3 months, her vision improved uncorrected to 20/60, in glasses to 20/30 +2, with a much, much more manageable refraction to wearing glasses. So this patient actually ended up being able to wear soft contact lenses on top of the CTAK segment. So she had now had soft contact lenses open to her, glasses correction open to her. And truthfully, 20/60 uncorrected vision, she actually had some level of walk-around vision, which she had never had before. This was better than what she had in her PKI. Next patient was a 19-year-old. He was in college, up many hours of the day. He said studying, sure, doing other things as well. But he was becoming more and more contact lens intolerant because as the day went on, he was a 24/7 contact lens wearer. And he really, as 8-10 hours went by, he couldn't wear them. But again, as a college student, he's not functional without his contact lenses. 2200 uncorrected, 20/70 in glasses, and again, a fairly unwearable refraction in glasses. And again, the same symmetric post-op result on a different cornea and very reproducible vision results as well. 20/50 vision uncorrected, 20/30 vision in glasses. Again, a more manageable glasses prescription that he can wear. And another patient who was actually able to wear soft contact lenses when this was all done, changing his entire life for a 19-year-old. Historically, a patient like this would have to have a corneal transplant to have any effective change in their life, especially if they're contact lens intolerant. And now they really have a new option that's open to them. So I'm going to turn it over to Dr. Berdahl. He'll also go over his early experience with CTAK as well.
Hey, everybody. What a great turnout. Thanks for being here. And let's see. All right. So here's a patient of mine. And you can see where the CTAK segment starts and where it ends. This patient before CTAK was 2200 uncorrected, had corrected vision to 20/30. And after CTAK, we took them from 2200 to 20/50 and from 20/30 to 20/20 in their corrected vision and decreased their amount of astigmatism pretty meaningfully. And you can see in the difference maps that it changed. But what I really wanted to share from my perspective is who are these patients? And how I think about this is these are patients that I want to be able to get into glasses with functional vision. So you take them from somebody that's entirely dependent on a specialty contact lens pretty much all day long to be able to see decent out of that eye. And the win is if we can take them from there to get into glasses. And the other thing that I'll share, and I don't have as much experience as these guys do, but I've done it. And I thought that it was going to be a really difficult surgical procedure to do. And it's not. And, you're taking this surprisingly rigid corneal segment, putting it in, and it's extraordinarily satisfying and even more satisfying because the next day they're already seeing better. And so as you see these things evolve, the classic story of, well, why do we need smaller incisions? Then we create foldable IOLs, and then we get even smaller incisions. To me, cross-linkings come, and what we were trying to do is prevent people from needing cornea transplants in the first place. So the best you can do is freeze it in place with wherever your jacked up cornea is. Now we're taking that jacked up cornea and we're normalizing it, getting people into glasses so they can have a break from their contact lens, improving their quality of life. And then the fact that this is customizable adds all that iterative capability in the first place. Like we've done, thank you for letting me include myself in all the work that you guys have done. Is how many total have been done, CTAK?
Over 60.
How much different is the algorithm and the shaping of the corneas at cornea 60 than it was at cornea number 1? Did you guys get it right out of the shooter? Has there been a fair amount of, okay.
No, it really is an iterative process. And we are constantly working with our software technician to almost use a machine learning type of approach to make it better and better. And right now we're looking pretty good with what we have, but there's continuous quality improvement, as they say.
Well, and that's the thing that's exciting about this, because it's customizable. And you don't have the same you don't have to design lock something to take it through an FDA approval process. We're doing a customized procedure to get the cornea to where we want it to be. And so go.
Okay. So we thank you all. We're going to take a number of questions should you like. But just to kind of reiterate what we are doing here, we really look at this as being a customizable lamellar keratoplasty procedure. Remember, in the old days, if we had a patient with severe pellucid, for instance, we would hand cut an arcuate inlay and actually suture it over. And now that we are in a different decade, we are able to make these inlays to exacting specifications because we now have the femtosecond lasers. We're able to utilize various aspects of corneal topography to get something that is really a best fit for that patient's cornea, which will give us the best ultimate vision results and topography results. And I think we've lost our slide. Oh, there we go. And again, using the CorneaGen tissue, which they really have made so it can be cut to exacting specifications, and importantly, is well tolerated by the cornea over years and is very, very clear. The instrumentation that we have, as Dr. Berdahl was saying, really makes this a very straightforward procedure. And the proof is in the pudding. We're getting real good, exciting results, great corneal topographies, and most importantly, really happy keratoconus patients. So I thank you all for coming.
How about the reimbursement? Do you bill as a lamellar keratoplasty? How about the issue reimbursement? Is it considered as experimental?
Yeah, the question is the issue of reimbursement. We're CorneaGen, I know, and is working on this a lot, and we're developing a good pathway for the billing that we think should be something that is easy to do in your practice.
So we are going to take a bunch of questions, and that's a great one. And I'll tell you, yes, we bill lamellar keratoplasty in our practice, and oftentimes the billing doesn't as precisely catch up with exactly what we're doing. But I think that this fits into that category, or it's the category that it fits into the closest. And then a question would be, okay, so if you're doing the femto maybe in your laser suite, and then you're going up to an ASC or doing something that later, I think that you can do that safely too. And so ask us the tough questions. We'll try to not answer them as hard as well as we can. But I have a question right before I come back to you. And so Steve, I wanted to go to this case. Will you this was your first case that you presented. Will you show us where the CTAK segment starts and ends?
Sure. So in this case, you can see that the CTAK segment this one's about 300 degrees. So we're kind of starting up here and ending right around here. We do these as much as 330 degrees. So the segments and if you look at your case.
Yeah, so go back to yours one second. Look at what I was struck by is here, how symmetric that flattening was. Right up here, kind of where you maybe didn't want to get it is where you didn't get it. But, 10, 11, 13 diopters of flattening all across that cornea because it kind of hugged it all the way around. And then if you go to mine, much shorter segment that you can see here that lifts that cone much more from inferior to being more central. And so I just wanted to point that out, and that's the power of that customizability.
And it's also where the instrumentation has really proven itself, because to get the 300, 330 degree segments in, we are now able to do that as one segment. So we started off by actually placing two separate ones, and now are placing everything as one single segment, where the instrumentation that's been developed allows you to both push and pull some of the segment in both directions and makes it pretty easy to get even the longest segments in.
Does it matter whether you have patients that work looking before or after the procedure?
Okay, question number one, does it matter if the patient was cross-linked before or after? I don't know, but in my mind, I'm only going to do it afterwards, so that I've got a stable cornea that I'm making incisions into, unless these guys tell me that they've got data that says to do it before. Do you guys?
So, I mean, we've done it both ways at this point. Naturally, we had a bunch of patients who had cross-linking done even 5-6 years before, and we're now having the CTAK segment done. Interestingly enough, it was not any more difficult to make the channels, dissect the channels, or place the tissue, whether they were cross-linked or not. I would say most of the patients that we do now, we do the CTAK first. Yeah, and then we do the cross-linking after. And that's actually probably historically from what we found with Intax, which is we did a lot of work on, and we actually published on it years ago.
Shape it, then freeze it?
Intax, and it seemed actually it was the same. The results were exactly the same, whether we did them same day after. And so we ended up, that's how we did Intax historically, and we followed the same suit with CTAK.
You get a bigger response from the people who had cross-linking first and then had CTAK.
So it's hard to tell right now because a lot of the patients we treated had 12, 14 diopters of flattening with the CTAK segment. So cross-linking, on average is a diopter and a half. If you're lucky, it's 2. So it's a little hard right now to tell when you're in these ranges of flattening how much more you're getting with the cross-linking. I would imagine as you move into more mild cases where the flattening is 3 diopters or 4 diopters, it's something to account for more that they might go to 6 or 7. Yeah.
But we do tell them that CTAK and cross-linking are done for entirely different reasons. Cross-linking is to keep your cornea stable so it doesn't get worse. As you all know in your practices, a lot of patients think that cross-linking is going to make their vision better. So it's very important to educate them. I say we have 3 ways to go. We need to keep your cornea stable. We need to get your vision the best possible. And there are ways that we can now do to make that cornea even give you better vision than you have now.
Is there a minimal PAC reading that you want to see in the apex of the cone?
The apex, it really is in the channel. But and what we find is that since this is corneal tissue, that the risk, and obviously we don't have enough patients that much time, but the risk of extrusion, the risk of melting is dramatically less. So we were able to put these into much thinner corneas than you would do with like an Intax.
Other questions?
How thick is your overlying cornea over the area of the channel?
So the question was, how thick is the overlying cornea in the channel? So we are generally placing these at about a 200 micron depth for keratoconus. For ectasia, we've moved the depth to 250 because we had early on some issues getting into, especially patients who had old microkeratome flaps, being in the interface when the channel was not deep enough. So we give that extra 50 micron cushion in ectasia patients just to make sure that we really have a clean dissected channel to place it.
Other questions?
Which laser did you use to make the channels?
Yeah, go ahead.
So the question was, which laser did we use to make the channels? We used the Z8 laser. I know that.
We use the IFS.
Yeah.
Right, most femtosecond lasers have the ability at this point to create these kinds of channels. And we hope to be continuing to develop with the companies more dedicated software, perhaps, that can even further customize the types of channels that we're making in the future.
Yeah, the nice thing about the Z8 is that it has the mobility to, if you want to do this in the OR, and there may be certain reasons to do it, you can actually roll it into the OR, make the channels, and actually place the segment right on the spot.
Make channels in one.
You can make channels in one room and do it in the other as well, yeah. Yep.
But in theory, you can make the channel earlier on. And as we know, as with LASIK flaps, do the procedure at another time.
So, in the old epicuratophagio world, how do we know what's going to happen to these segments 10 years from now? Are they going to go away?
Yeah. So the question is, are the segments going to melt or go away over time? Yeah. My Despite my gray beard, I never did epikeratofakia.
Nor have I.
Peter, do you have a comment?
I remember taking the epikeratofakia course, the living contact lens.
Yes.
The biggest problem with epikeratofakia, and indeed the onlays that they were using for keratoconus, is with the suturing, they were quite irregular. The quality of the tissue, this was simply lyophilized cornea, so the quality of the tissue was not great. It was hazy, or certainly nothing like we have now. At best, you had problems with epithelial ingrowth and poor epithelialization. So we hope to circumvent most of these things, given that this is an intrastromal procedure. There are no sutures involved. We can smooth the tissue very well. And at least in the several years that we've been doing it, the tissue has been highly compatible. Obviously, in the years to come, we'll need to do histology and see, do we have keratocyte ingrowth from the patient's own cornea? How good is the general incorporation of the tissue into the patient's cornea? It begs the question, if this is incorporated into the cornea as really a part and parcel of the corneal tissue, will this help to stabilize the keratoconus as well? Are you really restoring a corneal structure that's much more like normal than we have been able to do with other procedures?
The first inlays that we placed in a different iteration than this were actually now 7 years ago. So those have not, we still see those patients back, and those have not changed, thinned at all over that time.
But again, we do cross-link these patients. We're not counting on the CTAK to diminish progression.
Other questions?
Great.
Thanks, guys.
Thank you.